Good morning and welcome to our event to acknowledge and recognise that the World Patient Safety Day for 2021. I'm welcoming all those who had signed in from the patient safety research centres, translation research centres across the UK, to the UK patient safety community, to the patient safety collaboratives and the Q fellowships, but also to the many who are going to be joining us from the Global Patient Safety Network and also our own hosted Global Patient Safety Collaborative, which is supporting low and middle income countries and work in India, Pakistan, Kenya and Mongolia, to name just 4 countries. But also the many collaborators that we have across the world in patient safety. This is our 3rd event to recognise patient safety, and it's our 2nd virtual event due to the ongoing conditions that we find ourselves in. But we've learnt much over the last 18 months and we'll continue to learn how to deal and how to support not just our patients, but our healthcare workers as we strive to maintain not just the quality of care, but reduce the avoidable harm that is currently in place across the world. We started 3 years ago for our first World Patient Safety Day, and there were tens of events around the world. We now know from the networks that are in place, there are thousands of such events taking place yesterday, today, tomorrow, and early next week. And that's a testament and a testimony, I think, to the commitment and endeavours of patient safety champions, of experts, but most of all, I think, of patients and their affected families, as we start our decade of action to introduce a global patient safety action plan. And I think this is the watchword for today, and it's the watchword for the next few years, is that we want action. We want to see action, not just planning. We have no longer got the time in many of the other events that are taking place across the world with regard to climate change, with regard to infection prevention and control. This is now the decade of action before we run out of time. So this is what I'd like us to concentrate on. We're going to have a very busy schedule this morning. Our theme, as you know, this year is maternal and newborn health, and we have a star-studded lineup to help us navigate our way through what are the key elements for ourselves, but also for the systems, for our expert knowledges, but also for our families and the patients who may become patients within their families. Because most of all, we like to see this as a non-patient experience. I'd like us now to move to our first speaker, and it's a great privilege to be able to have Professor the Lord Aradazi speak to us. He is the director of the Imperial Patient Safety Translational Research Centre, supported by NIHR, and for a long time he's been leading globally work not just in the quality of healthcare, but in supporting populations and vulnerable populations across the globe. So it gives me great pleasure to be able to introduce his pre-recorded video. Thank you very much.
Distinguished guests, ladies and gentlemen, good morning and welcome to the 3rd Annual World Patient Safety Day. It's really a great pleasure to have so many of you with us for this virtual celebration. Since we met last year as a global community, we can reflect on some of the incredible scientific progress in the discovery and the effective implementation of a vaccine program, let alone the many new therapeutic agents we have today. Thanks to the NHS, thanks to NIHR, and thanks to the many members of the public and patients who really recruited into these amazing clinical trials. Furthermore, the resilience of those within the healthcare system across the globe and their unerring commitment professionalism, and sacrifice in the face of such adversity has truly been humbling and inspiring. However, this has unfortunately come at a cost, and as part of today's proceedings, we will have an opportunity to reflect and discuss some of the key challenges for health systems in building a resilient workforce as we move to the next phase of this pandemic. The team at the National Institute of Health Research at Imperial College Patient Safety Translational Research Centre is working on a number of initiatives aimed at generating academic evidence addressing resilience in our healthcare workforce. A programme of work with the Behavioural Insight team and the Royal College of Anaesthetists run a randomised controlled trial to evaluate the impact of novel text messaging on burnout in trainee anaesthetists. And we also have a further work stream with the Behavioural Insight team focused on burnout in nurses, for which a preliminary data will now inform the development of an intervention to reduce burnout in these settings. We have also heard the voices of more than 1,600 general practitioners worldwide on the benefits and challenges of new modes of delivery of care using remote technology and identified important impacts on burnout and workload. We are now incorporating these findings into the development of a safety checklist for remote care that acknowledges both patient and staff priorities. Patients have also experienced massive changes in the way they access and receive care. An important group adversely affected during the pandemic has been pregnant women, with increased uncertainty caused by necessary restrictions put in place by maternity services, resulting in feeling of distress, anxiety, and isolation. Maternity has been the core focus in relation to patient safety, and it is within these important issues in mind that I commend my colleagues at the WHO in selecting the theme for today, safe maternal and newborn care. Restrictions during the pandemic were introduced to keep women, babies, and staff as safe as possible, as the unknown impact of the virus unfolded, but have nevertheless had adverse psychological consequences to many. Maternity services and their staff have faced unique challenges in continuing to provide safe and accessible care during this time. Despite the global efforts, important health inequities still remain in maternal care. Women of Black and ethnic minorities background may be at a higher risk of complications from COVID-19. Maternal mortality and stillbirth rates are higher for those from Black minorities and ethnic backgrounds, those with underlying health conditions, and those who are socially deprived and facing other forms of disadvantage. Vaccination is important for pregnant women, with emerging evidence of increased risk of severe illness and premature birth. We are now seeing that COVID-19 vaccine hesitancy is high among pregnant women, and particularly among those from ethnic minorities. And it is vital that this continues to be addressed. At a time when healthcare systems are under extreme pressure, it is important that women still receive safe, respectful maternity care, and the undeserved or disadvantaged groups must be kept safe. The global patient safety movement must work to provide patient-centered, safe, and respectful care for women and place them at the center of efforts to continue in reducing avoidable harm and death and improve safety in maternal and newborn care. To seek to address these challenges, we are joined by an eminent array of knowledgeable speakers today. Following this introduction, it's a great pleasure and honor always to introduce the Right Honourable Jeremy Hunt, who has championed the cause of patient safety throughout his time in government and now as the CEO of Patient Safety Watch. Dr. Mike Durkin will then chair a live panel where we will benefit from the insight and knowledge from leaders across the global patient safety and maternal and newborn health communities, including Dr. Aidan Fowler, the National Director of Patient Safety in NHS England and NHS Improvement, a great colleague, a great leader who had an impactful impact in terms of his influence on improving patient safety. Dr. Susanna Suleiman, Head and Senior Consultant, Department of Obstetrics and Gynecology, KK Women's and Children's Hospital in Singapore. And some will know KK Women's and Children's Hospital is one of the largest maternity hospitals in the world. Professor TJ Teo, a consultant obstetrician, gynecologist, and Director of Women's and Children's Services at Imperial College NHS Trust. TJ has been a colleague of mine for many, many years. We're actually, in fact, qualified from the same medical school. Darren Welsh, Director of the Global Health for Foreign and Commonwealth Development Office, and Mandy Forrester, Midwife Advisor for the International Confederation of Midwives. I'm also delighted that we're also joined by Professor Jacqueline Dunkley-Bent, England's first Chief Midwife Officer and the National Maternity Safety Champion for the Department of Health and Social Care. You are most welcome, Jacqueline. Thank you for making the time. During the course of today's proceedings, we will dive into conversations with our experts to better understand the impact of COVID-19 pandemic on service users, maternity staff, and on the services provided during this time. We hope to have a rich discussion considering the challenges and opportunities that COVID-19 pandemic has presented for maternity services, and how might this change the nature of them in the future. Our vision is that this diversity of expertise will facilitate dynamic ideas for ensuring safe and respectful childbirth, and I encourage you to join in with the discussions and share any questions for the live questions and answer sessions. In summary, I can thank once again everyone who has joined today, all our speakers, and the team at NIHR Imperial PSTRC for orchestrating this event under the leadership of Anna. I hope all of you will have a great day and enjoy what I'm sure would be a stimulating program. Thank you.
Ara, thank you. And thank you very much for that great introduction, which has also helped me to introduce the panel later on. So thank you very much for that. I'd also like to remind us, before we go to our next speaker, of the importance of thinking about what questions you would like to pose to the panel over the next 30 to 40 minutes, so that we have a rich vein of questions. They're nervously waiting for these questions, and I can see them all on my screen now, and they're starting to get more anxious as I keep talking. So we want to put them under pressure because they're our leaders, and we want them to really be telling us and helping us what actions we should be putting in place and how they're going to help us do that for the future period. What I'd like to do now is move to our next speaker. Our next speaker is known to everybody for different elements. I think he's known more now for his work in supporting global patient safety efforts across many different countries in the world, which is work that probably has not gone that noticed in this country. In this country, he's the chair of the UK Parliamentary Health and Select Committee, and to that end, he is holding the system to account with that committee, and holding Parliament to account with that committee. So without further ado, I'd like to move to introduce you to the Right Honourable Mr. Jeremy Hunt for his address to us this morning. Thank you.
My name is Jeremy Hunt, and it is a huge privilege to contribute to this World Patient Safety Day event organised by Imperial College, and I want to start by thanking all of you, the champions of the global patient safety movement for helping me to understand when I was Health Secretary that this is one of the most important things that people running healthcare systems need to put right. And I particularly want to thank Lord Darzi. Ara has become a great friend and was thinking about this when he was a health minister long before me. For people like Mike Durkin, who've guided me along the way, Liam Donaldson, who did so much when he was Chief Medical Officer, and also to Dr. Tedros at the World Health Organization, because it is thanks to him listening politely to my lobbying and campaigning that we actually have ended up with a World Health Assembly motion that means we have a World Patient Safety Day every year on September the 17th, which is a huge and exciting thing to happen. But there's one group of people that really I want to thank more than any other, and that is the patients, the families, the campaigners who I met when I was in office and who helped me to understand that something was very seriously wrong. And people like James Titcombe, who had to write 400 emails before the NHS would tell him the truth about what happened to his son Joshua. Julie Bailey, who had to camp outside the Department of Health in the cold and the snow and was refused the chance to meet anyone. Derek Richford, whose son was lost at one of the East Kent hospitals, again had to campaign for years before the truth came out about what happened to Harry. These are the people who made me realise when I was at the top of the pyramid that life at the bottom of the pyramid is very uncomfortable. And I want you to picture what it's like when you have the privilege of doing a job like Health Secretary. You may not know a great deal about health policy. I certainly didn't at that time. And I had to deal with the scandal amid staffs. And I started to be told by bigwigs in the NHS that patient harm was an inevitability, that we were always going to harm around 10% of patients in every healthcare system in the world. And then I asked how many people died. And it turned out in the NHS, because we're good at measuring these things, it was about 4% of hospital deaths that had a 50% or more chance of being preventable. That means essentially around 150 people a week. 150 people a week are just dying avoidably in our hospitals. And the NHS is by no means unique. This is broadly average for developed healthcare systems. And yet we take it for granted. We sort of assume it's a cost of doing business. And as someone who doesn't come from a medical background, I felt something wasn't right. And I began to worry that there is just too much death in the business of healthcare for the simple reason that half of us die in hospitals. The average hospital in England will have about 50 deaths a week. The mortuaries are busy places, and 2 or 3 of those will have been preventable. But because there are so many people dying, no one really wants to take the trouble to find out which of those deaths could have been preventable, because they quite understandably want to focus on the patients who are alive. And the result is that in modern healthcare systems, we don't have the shock factor around a preventable death that you would get in the airline industry, the oil industry, and the nuclear industry. And so I started to think about what could be done. And I think one of the most challenging areas to deal with emotionally is maternity, where we have one of the higher baby death rates in Europe. In fact, if we had the same maternal safety rates as Sweden, we would have 1,000 more babies living every year just in England. And the heartache is unimaginable when you meet families faced with that. And having 3 young children myself, I found myself shuddering at the thought of what would have happened if one of those families had been my family. So I went on this journey from being shocked to thinking something must be done. I commissioned a whole series of inquiries, the Morecambe Bay inquiry done by Bill Kirkup, the Shrewsbury and Telford inquiry that's just reporting, perhaps early next year, will be concluded by Donna Ockenden, and we had the second Francis review, a whole series of different reviews, and from those reviews came a whole bunch of actions. And my first reaction was to say this is really all about transparency, and we've just got to get this out in the open, the fact that we're having all these tragedies. And so I introduced the duty of candour, the new Cqc Inspection Regime, one of the toughest and most transparent in the world. We set up new bodies like HSIP to do independent investigations into the serious maternity incidents, the national maternity safety ambition to halve baby deaths, maternal deaths, and serious injury by 2025. And all these initiatives came together, and we have had some good results. And I think it's important on World Patient Safety Day that we recognise the progress that's been made over the last decade. The number of neonatal deaths has gone down by a quarter. The number of stillbirths has gone down by 30%. So important progress has been made, and yet we still have these 150 avoidable deaths every week. We still have many more babies dying than is necessary, and this is a global problem. And the more I thought about this, the more I concluded that in the end, the way you change these things is not from a politician on high saying this is what needs to happen. Bill Clinton once said politics is like working in a graveyard. There are lots of people underneath you, but they're not necessarily listening. But that isn't the way you address these problems. The way you address these problems is with culture change that comes with inside, because a politician, a system leader, a boss can make an order, a request, introduce a target to deal with one specific problem. But the truth is, you can't set up a system where every new problem that occurs automatically ends up being self-corrected, and that's what the highest performing organisations do, and they only do that by tapping into the genius of each and every person on the front line, by creating a true learning culture, so that every time something goes wrong, people have the space and time to learn what went wrong and to design those problems out of the system in the future. And the truth is that in modern healthcare systems, instead of a learning culture, we still have a blame culture. If you could imagine the most awful thing that could happen in the hospital, and I've asked this question to many doctors and nurses, they'll often say when a baby dies for reasons that could perhaps have been avoided. Professor Albert Wu, who's a great patient safety campaigner from Johns Hopkins University, coined the phrase second victim to describe the doctors and nurses responsible in such a situation for that child's care. The emotional impact on the doctors and nurses is almost as great as on the families, but the doctors and nurses have to go back to work the next day, wrestling with the fact that they may have been responsible for a child's death. And in those situations, the memory plays tricks with you. But if on top of all of that, you are terrified that you're going to get fired by your hospital, you're going to get criticised by the CQC, you're going to be struck off by the GMC or the NMC, you're going to be sued, you're going to be found guilty of professional negligence, then all sorts of fight or flight mechanisms kick in. Sometimes quite unintentionally, you misremember what happened, you feel extremely defensive. Often you're advised to stop talking to the families except through lawyers. And the one thing that those highly ethical doctors, nurses, midwives want to do more than anything else, which is to be open and transparent about what happened with families, to help their grieving, to learn any lessons, to make sure that same mistake doesn't happen again, either in that hospital or any other hospital. The most important thing of all, that we learn from a tragedy, ends up being the one thing that doesn't happen. And that's why, for me, it's important for system leaders like you to do everything they can to support patient safety. But in the end, the real insight is to know that change has to come from the bottom up. And all we can do is to create the conditions, the culture, the atmosphere that supports brave doctors, nurses and midwives to do the right thing, to learn from mistakes, to be open and transparent. And that means changing a blame culture for a learning culture. And this is what has been successfully achieved in other industries. We've talked about the airline industry, the nuclear industry. They're just two of the many industries that have achieved this, but we have different challenges in healthcare. Now we need to do the same, because across the World Health Organization say there are 2.6 million preventable deaths every year because of lapses in patient safety. 2.6 million makes patient safety errors, medical error, one of the 10 largest killers in the world, above malaria and TB, but below AIDS and road traffic accidents and cancer. A seriously large number of lives could be saved if we crack this problem. But the great thing is that, unlike with cancer, we don't need any new technology, new medicine, new treatments to do it. It's simply about following best practice and making sure we have a culture that makes it easy for hospitals, doctors, nurses, frontline workers to follow that best practice. Across the world today, every single day in childbirth, 800 mothers die, 7,000 babies die. That's why for this year's World Patient Safety Day, the theme has been maternal and neonatal safety, and it's a theme that we want to champion across the whole world. So I want to thank you for your tremendous support on World Patient Safety Day, and I want to leave you with a saying from someone who had a great influence on me, not when I was Health Secretary, but actually when I was Foreign Secretary, one of the wisest men I ever met, Dr. Henry Kissinger, probably the world's most experienced diplomat. He described diplomacy as the patient accumulation of partial victories. Well, I think that's the best way to describe progress in patient safety too, the patient accumulation of partial victories. Don't be disappointed if it's only a partial victory. Don't be put off by the patients involved. Lives are being saved every day, every week, every year because of the work all of us in the global patient safety movement are doing. Thank you for your tremendous efforts.
Jeremy, thank you, and thank you for that, and also thanking you for reminding us of the importance of, as Mr. Kissinger said, those partial victories, because it's the accumulation of those partial victories that not only give us great opportunities for widespread change and often rapid change, but also gives us a confidence as individuals to take on this mantle and to carry on working to support the reduction of harm in all settings, in every setting. And in that context, what I'd like to do is now to move us on to our next phase of this morning's work. And that is to introduce you to the panel. But before we go to the panel, we believed it was important not just to listen to their expert views, I'm sure we'll have time for doing that, but also we wanted to listen to some people who had some real life experience in recent months for their own maternal journey. We conducted, or the team at the Translation Research Centre conducted 2 focus group sessions with these very brave people who have kindly allowed us to show their photographs on the screen today. We carried these focus groups out because we really wanted to find out from them what their shared experiences were of being pregnant and giving birth, but also of the services and the access to services that they had have had during COVID-19 pandemic time. So I'd like to just take a moment to thank all of these women who've participated in the focus groups, but also to thank them for sharing with us in a very candid way their experience and their thoughts. The team have put together a new word for me, a Jamboard, based on the key messages raised during the focus groups, which I'm hoping you will now see on the next slide. I've tried to précis this Jamboard, which has now appeared, in a number of ways. I think there are 4 key elements, because I'm not going to read them out for you, but there are 4 key elements I think that come out from here. One is, what did the pandemic and the new modes of remote health services delivery mean for mothers and babies? We're relying more and more on remote systems, both digitally and through many other different methods. So particularly for those with complex healthcare needs, what does the pandemic and new modes mean for that? A second one is, how can women be supported more, given the feelings of isolation, fear and often anxiety normally experienced during childbirth, but often increasingly when they are unable to participate in some decision-making processes. And this has particularly been highlighted, I think, with the added challenge of partners not necessarily always being able to be present during different elements of their journey to delivery. Another element for me is, what was the holistic and specialist support could be offered? What could be offered in cases with a history of miscarriage or complications, difficult labour, babies with complex needs, mothers with underlying heart conditions? That seems to come out as a fairly consistent piece of what further support can be offered for those states. And then I think probably actually consistent with other areas, how appropriate and consistent advice and guidance could be developed to help women make important decisions, particularly in the varying flows and fluxes of the context of the COVID-19 pandemic, where different advices and social media has a big part to play in the variability of evidence that have often been given to us. So today I'd like to use the panel session to consider some of these themes and some of these frames that we've suggested, and we'll bring them together now to let us listen to their experiences and their expertise. So I'd like to now open up the panel, and just to remind you across the country and in different countries to post your questions to us. So at the second phase of the panel, we'll actually be going to your own particular Q&As. So first of all, I'd like to open up the panel session, and I'm hoping that seamlessly and virtually our production team will be able to bring that into play. So thank you, Sam. If we could now introduce the panel. So I'm told the panel is now live, and so I will now introduce the panel. Here we go, the panel view has come up. Thank you very much, Sam. Thank you. So, gosh, they're looking even more nervous now than they did when they were in their own little private screens. So first of all, in no particular order, I'm just going to go around the room as we've got it in front of me. So first of all, I'd like to introduce Susanna Suleiman, as Ara has said, leads the work in one of the largest hospitals in the Far East, and certainly in Singapore. So thank you very much, Susanna, for joining us here today. Mandy Forrester, who is a midwife and now leads with the international side of elements in terms of the International Confederation of Midwives. Mr. Darren Welch, who is here in his capacity as Director of Global Health at the Foreign and Commonwealth Development Office, so the Foreign Office. And thank you very much, Darren, for joining us today. I know that given the events of the last 2 or 3 days, you've had a particularly busy time there, and so thank you very much for joining us today. Jackie Dunkley-Bent, who, as you've heard from Ara, apart from my own personal knowledge as just being a wonderful woman, is also the leading midwife in England and has charge of many different elements of change that are taking place across midwifery services. So thank you, Jackie, for joining us today. Aidan Fowler, a very old friend of mine, and he's looking very tired at the moment, but I'm sure we'll liven him up this morning. So Aidan has taken on the mantle of being the Director of NHS Patient Safety Services and is carrying this out, as Ara says, with huge aplomb, given the challenges that we are facing across the country. So thank you for joining us, Aidan. And last but not least, TJ Teo from Imperial College, another renowned obstetrician who is also going to be sharing with us his thoughts on where we are today. We're going to start the panel discussion with each member just introducing themselves, with giving them 2 minutes for them to say what in their view is their challenge from their remit with regards to a global movement to improve the care of our maternal population, but also our newborn safety. So I'm going to start with Susanna, and then we'll move around the room. So 2 minutes quickly, Susanna, on what you think are the challenges for you.
Hi, everybody. It's actually 5:37 p.m. in Singapore at the current moment, so it's pretty warm. So if I go off tangent, please guide me back. But anyway, I think the challenges mainly in Singapore is the fact that we had to come up with as many as the same as any other countries. I think when COVID came, we were just as lost. How do we set up the hospital? How do we protect the staff, the rostering, how patients enter the hospital? So each and every hospital derived had to come from scratch and had to have a process. So I think the main thing was to support from the very beginning, from the entrance, from how patients come in. The support is not only for the patients, but also the staff. Because as it is, we can't travel. We also have got staff who are actually from the overseas as well. Many of those who are unable to go back and see their families again, support is actually quite limited as well. So you can imagine how the emotions are, the support, long hours. And I think the other challenge is also to make sure that patients are safe at all costs, to do things right amidst the fatigue and also the evolving circumstances in Singapore. As it is, as you can know, starting from yesterday, we had 910 positive COVID positive in the population, and those are all community. So you can imagine that the numbers are now slowly going up, and we are slowly trying to see how we can do better to support the entire nation, actually. Thank you.
Thank you, Susanna. Thank you. Mandy, from the international perspective as a midwife and helping support the regulation and support for midwives.
Yeah, thanks, Mike. That's it's really interesting listening to Susanna there, because she's touched on some of the issues that what we found at the International Confederation of Midwives, and what we have found is that an emerging human rights issue. So we found that maternity and women's health haven't been considered in many places as essential services. And this has had an impact on safe care and access to care, and also for respectful care for women and girls. We have over 140 associations as part of the ICM, and they were surveyed and they've described the challenges that midwives have been faced with upholding safe care for women and newborns and their families. And throughout the pandemic, what we've all seen, and as Susanna really eloquently said, you know, we've had to respond to an unfolding situation, and this has meant in some cases inappropriate protocols for the management of pregnancy and birth and postnatal care in response to the pandemic. And as a result of this, what our member states have reported is that this has challenged safe and evidence-based care within our sector. Women and girls have largely been forgotten and disregarded by systems that are designed to uphold their rights and safety. And what this overall impact of this has been an increase in gender discrimination, domestic violence, human rights abuses, the over-medicalisation of birth in many cases, fear, misinformation, and of course what this has done, it's all culminated in growing distress amongst midwives and the women and the families they care for. If I may just give you some data that came from this research that the organisation did. 80% of women reported that they were afraid to attend maternity facilities, and attendance for care has dropped by 75%. 30% of maternity facilities were closed and turned into COVID-19 facilities. 40% of women have resulted in giving birth in places different to where they originally planned. And most startlingly, 10% of women have reported being unable to have access to a midwife at all, so birthing unattended. And I'm sure more will come out as we go through the morning. Thank you.
Thank you, Mandy. And some very important data there, and distilling the information from that data is going to be vital over the next decade. So thank you for that. If I may just change the order a little bit and go from midwife to obstetrician. So if I go to TG, so where are you on this agenda, TG, and what do you think are the key challenges for the obstetric world?
Thank you, Mike. So from the Imperial perspective, we're one of the largest deliverers of maternity care in the UK. I had the privilege to work with Jackie Dunkley-Brent, who supervised me on quite a few things as well. I think the biggest challenge is the giving of information and communicating to our staff and our patients of the evolving impact of COVID. We found that the biggest challenge is how do we treat our patients if we don't care for our own staff. I mean, Jackie knows that I always feel that if we care for our staff, then they will feel well looked after, they'll feel motivated, and they can then come into work and give proper care to our mothers and the babies. And the challenge for us was keeping our staff up to date with the changes in COVID restrictions, the treatment, the management of COVID. How do we evolve to teleconferencing, to virtual outpatients, which probably in maternity doesn't quite work because there are certain intervals in pregnancy that you do have to see this woman. And a virtual conference does not really impact it. You can't monitor the baby. You can't look at the mother's well-being as well. So I think these were the biggest challenges for us. I really feel that the best thing for this kind of, for looking after our staff is clinical leadership. So we had daily walkarounds for my senior clinical teams. We had information updates. We had WhatsApp. We had emails. We had evening walkarounds. I still remember the really funny thing, and I still remember when the start of COVID around March last year, and I was talking to a gathering of midwives and doctors in a ward round, and we're talking about COVID, and someone asked me, so is the lack of sense and smell part of COVID as well? And I go, no, not really. I don't think it's one of the symptoms. And then 2 weeks later, it's one of the big symptoms. So I think keeping up to date with communication, information, looking after our staff who will then feel inspired to look after our patients, for which there have been huge challenges, and I'll come on to them later on because the challenges for them. One of the biggest things we found, which is very sad, is yes, we acknowledge that a lot of our women felt isolated, not looked after. And so because of the fact that they weren't allowed to bring in their partners into the labour ward suite. And so the midwives and doctors, but more the midwives, had to do the job of being a caring professional, but also a supportive professional. And one sad bit was that there is an increase in violence and aggression to our own staff by not so much the patients, but their partners. So there's something we've got to look after. If we don't look after our caregivers, I think we'll have a problem. Thank you,
TG. Thank you, TG. And we'll have an opportunity, I think, to explore some of those challenges with you as over the next phase of the panel. Darren, I wonder if I could come to you next. You're used to change, and you're going through a period of acute change at the moment in the FCDO. What do you think are the challenges that you've seen in terms of your global health director role with regard to the presence, if you like, of the FCDO around the globe, particularly thinking of those countries where they may be of low resource, where the challenges are accumulating? Thank you.
Great, thank you for that, and thank you for inviting me to give a slightly different perspective perhaps on some of these issues. I mean, the first point, of course, is that the COVID pandemic has made everything much harder, including and especially perhaps our work on health. And we work in countries where systems were already weak, fragile, under huge pressure, under-resourced, and that's all become much more difficult. Not just the systems, but also, it's estimated that more than 150 million additional people could be pushed back into extreme poverty by this pandemic, which has, of course, inevitable impacts on their health and the accessibility of healthcare as well. So the situation is a lot more difficult, and unfortunately, that comes at a time when we had been making good progress on many indicators, and now there's a real risk of going backwards. So we're responding to this in a number of ways and see a number of challenges around this. So first of all, we want to be driving our work on respectful maternity care and patient safety as part of that through our overall programming around the world. And we're present in a good number of countries across Africa and also some in Asia as well. This government had a manifesto commitment to work towards ending the preventable deaths of mothers, children and newborns. And we are looking at how we can do that in this new environment in the way that's most impactful. And we are going to be taking a systems-based approach, so looking at how we can support countries to develop those strong health systems in a way that provides respectful maternity care. I think you mentioned the new FCDO is a time of change for us. We are partway through a merger, and these things take time, but that gives us a big opportunity to put ourselves in a campaigning mode, which brings together our development expertise, but also our diplomatic presence around the world and the capabilities we have, the links we have, connections into governments, to, as I say, to get onto a more campaigning footing on these issues. And we've also got an opportunity to strengthen the partnerships we need to deliver that change around the world, and linking back into the fantastic UK resources, obviously the NHS, but the research base as well. And in fact, we work very closely with many of the partners here today. And then another challenge perhaps is switching our mindset from one where we focus very much on achieving greater coverage to one where we focus on the quality of the care, and that's going to take a little bit of time as well. So challenges, but lots of opportunities for us as well, and we're excited about that. Thank you.
Brilliant, Darren. Thank you. Thank you very much. So, Aidan, particularly challenging period for you over the last 18 months or so, and I guess for the next 18 months, and then going through to the decade of action plan for a global action plan. What are the challenges you think are really sort of stressing you at the moment in terms of the UK or England in particular, I guess?
Well, I think there are a lot of challenges, as you say, but I think it starts with learning, Mike. So as SRO for two very significant maternity reviews, those of Shrewsbury and Telford, which has published its first report with the second due, and East Kent, I have a responsibility for making sure that we learn from what has gone on in those organisations and what we can change, and to make sure we take action on that. And we are already doing so. So following the Morecambe Bay report, there's been the amazing maternity transformation programme. Following the first report that Donna Ockenden produced in Shrewsbury and Telford, we've taken a lot of actions to try and move progress in maternity on further. So you'll see that we've focused significantly on workforce and putting resource into making sure that there are enough midwives and obstetricians to provide the service, as well as a whole variety of other actions. I've been working with the maternity transformation plan to try and take the next steps with that. It's now 5 years old, and we've looked to revise that. It's been an incredible journey, but it's been at times perhaps quite complex to get your head round as a frontline clinician with 10 work streams. And I'm really pleased that we've taken an approach that aligns now with our overall patient safety strategy, which perhaps well, at least our expectation is it will make it more accessible to staff on the front line. I just wanted to also come on to the issue of inequalities. So Jackie and I have just come off a webinar talking about maternity separately with the patient safety team and others. And the subject of inequalities was very strong. And in addition to thinking about inequalities specifically in maternity, we've done some work over the last year, learning from COVID about the importance of inequalities in patient safety and in harm particularly. And what we've seen, which will be a surprise to nobody, is that harm is unequally experienced by different groups. And I think often we focused on individual reasons. So we focus specifically on maternity issues, stillbirth or neonatal death, particular groups. We focus on falls and pressure ulcers in wider patient safety rather than the generic features of that. And what we've been working on is what are the reasons why in general harm is experienced more by certain groups, and understanding cultural competence of staffs, communication skills with different groups. And now we're into the phase of how can we correct some of these issues? So how can we develop communication techniques which are, if you like, agnostic of your background, and safe techniques? And we get this wrong for particular groups, but actually we get it wrong for everybody sometimes. So we're working on that. When we start to make improvements on this, just to finish on the international bit, then I think at that point we'll want to start sharing some of that learning around the world, and along with finding out from others what they've done that works well.
Great, thank you, Aidan. And again, we'll be able to explore some of those elements, I think, more deeply as the panel progresses. Jackie, over to you. Leading a great piece of work across the country, and have done so for a few years now. What are the current challenges for you, do you think, that really set the frame for this morning?
Thank you, Mike, and thank you for the opportunity. And before I start, I always reflect actually on World Patient Safety Day about our colleagues globally who have huge challenges with the number of maternal deaths, for example, every day. Global estimates are 810, one stillbirth every 16 seconds. You know, these data are really, really sobering. And when I think about the challenges that we have in England, whilst different, we have some really huge challenges in delivering on the ambition, and we've made some great progress. Jeremy Hunt referred to the national ambition, which is to halve stillbirths, intrapartum brain injury, maternal death by 50% by 2025, and preterm births from 8% down to 6%. So that's an awful lot of data, but in terms of the human experience, what that means, Jeremy alluded to this, is that we want a healthcare provision in England where we have the best outcomes and the best experiences for mums and babies. So some of the challenges that exist are, number one, meeting that ambition, and we're doing phenomenally well. We have the lowest stillbirth rate on record, but we have much to do because, as Aidan referred to, there is an inequality in health outcomes. And that is a huge challenge, one of our biggest challenges at the moment. Maternal mortality, we are reducing our maternal mortality, but the rates are still high if you are non-white, if you're from a Black, Asian and most deprived background. For stillbirths, we are doing a phenomenal job in reducing our stillbirth rates, but we aren't moving fast enough for women from an ethnic minority background. And I could step into the neonatal mortality space. We're doing a phenomenal job at reducing our neonatal mortality rate, but for Black, Asian mums and babies, the neonatal mortality rate for our babies is increasing for these ethnic groups. So we have much to do. That's our big challenge. That's against the backdrop of the COVID-19 pandemic. And we saw an inequality again with more women from a Black and Asian background being in hospital pregnant with COVID. COVID has really challenged. TG's already shared, one of the most phenomenal clinical directors that I've ever worked with, caring for people authentically. And he'll blush when I say that, but that is fact. But some of the impacts on our services have meant during the COVID space that we've had to suspend to ensure that the majority of people have been kept safe, suspend some of our services, for example, some of our home birth services. And that has come with its challenges because that's reducing choice and it's a difficult decision to have to make. That's just one example of many that I could give you. And similarly, other people have alluded to this, but in England, we have had challenges with women who have not felt safe entering our hospitals and our maternity services. So they have delayed in accessing care for much needed intervention for fear of contracting COVID-19. And also some have shared that they don't want to burden the NHS. And so they're just, and also just finally, what I will say is that this COVID has also shone a light on the challenges of fears and concerns of our staff, of our workforce. TG alluded to this. Midwives, obstetricians, anaesthetists, support staff, maternity support workers, anybody that is providing care within our hospitals today, they have felt fearful. And there is a huge fear as well from staff working in our NHS from a Black, Asian, minority ethnic background as they watch the data unfold about that the challenge of COVID-19 on people from a Black, Asian and minority ethnic background. So that carries its own fear. So workforce, women and families who use our services against the backdrop of trying to achieve a national ambition and the inequality arm have been some of our biggest challenges in England.
Right. Well, thank you, Jackie, for setting out the challenges and also Aidan. So I'd like to maintain that that frame for us now. If we start some questioning, and I'm just thinking of a conversation maybe between you and Aidan in the first instance. So you've set out, I think, what are the current experience of how COVID has impacted on maternal and neonatal care, and just reflecting on the words and themes from the focus group, that also chimes really well with their views that things have been different and not altogether satisfactory for them. So I'd like to turn, instead of now of what the current state is, what is the ideal state? What are the actions that you can put in place to get there? So I'm just running, what are we doing about it in terms of those elements that you talk about, a number of those elements? So maybe Jackie first and then Aidan, or vice versa. I don't mind. We can cope with conversations across the screen, I think.
Jackie, you're the expert.
I beg to differ, Aidan, but nonetheless, we're a team, so it's great to have you with the team. So there are many things that we have done in responding to the concerns raised by women. We have a plethora of interventions, and just a few examples, if I may. We have a campaign called Help Us to Help You that has a focus on maternity and neonates, that includes, for example, changing the information on the NHS England website. Instead of saying stay at home, we are saying please engage, call your midwife, call your maternity team. We've produced activations that have been co-produced with women from disadvantaged backgrounds, women from diverse backgrounds, so that we're really translating some of our information in plain English. We have a publication of many of our information in many different languages. We've adopted and deployed the Attend Anywhere virtual appointments, and that hasn't come without its challenges. And I think TG alluded to the fact that the prevalence of domestic violence has increased. We can't see women physically. We've used the Attend Anywhere for some of our appointments, not all of them, because naturally antenatal care requires hands-on clinical presence. So, but nonetheless, the Attend Anywhere has been deployed for some appointments that could be virtual, but they do come with their challenges. We've deployed home blood pressure monitoring kits to avoid women from having to come to hospital simply to have somebody take their blood pressure. And there's a self-empowerment element in that as well that has been relatively positive. And we've had many services that have deployed COVID at home surveillance clinics within the woman's own home, where they've had O2 saturation monitoring, as I've mentioned, blood pressure monitoring, and a direct line on a daily basis with a doctor and a midwife undertaking online surveillance work and rapidly making decisions about who needs to come in and who doesn't. And that's just the starter for 10 of some of the things that we've done for women and families who use our maternity services. But we've also deployed support for staff, and that has been numerous in terms of webinars to encourage and engage them in understanding COVID, looking at the science, talking about PPE, dispelling some of the myths that constantly float around our social media that is driving vaccine hesitancy and incorrect information about COVID. And of course then a focus support for staff from ethnic minority backgrounds. I've listened and sat in on at least 1,500 attendees from these communities who share their own concerns. So that's just an example. Sorry to take up too much time.
No, great examples, and I'm sure we'll go around the room during the session for more examples. Thank you, Jackie. So Aidan, in terms of constructing a national learning system, then how are we learning of these great initiatives, and how are we spreading that learning so that we can give all systems an opportunity to see what works well and possibly to stop what isn't working well?
Okay, thanks, Mike. Lots to talk about. Before I do, I just want to reference vaccines. It's really important that people, particularly during pregnancy, who should be vaccinated are vaccinated. And we know there's been a voice against that. And we know that some of the champions for vaccination have had a really difficult time during that. And I just want to note that and their extraordinary strength and resilience in the face of some pretty unpleasant interventions, and how important it's been that they stood their ground on that. So I just wanted to recognise that to start with. It's been incredibly challenging for some of our colleagues, some of whom are present. Just on the subject of learning from COVID in particular, I think TG referenced people feeling alone because their partners weren't with them, and I can only imagine what it would be like to have an ultrasound and find some abnormality and not have your partner with you, and how difficult that was. I think we got it wrong, but it's easy to sit here now and say we got that wrong, knowing that actually the reason we were making those sorts of decisions is because people were doing procedures in small rooms, often not very suitable, crowded, and were, staff were rightly worried for their own safety. And of course, we didn't have the level of testing we now have, so we can look at this from a position of having as much testing as we need. And I know from my own experience only too well how much of a struggle it was getting testing in place at the start of this. So I think we did get that wrong. I think on the remote thing, it's become quite binary, this discussion about is remote care good or bad, and it isn't either. It's appropriate for some things. We've learned a lot about working remotely, both as staff and working with patients. I've had the experience of both remote. I actually got COVID and some long COVID symptoms. I'm in a luxurious position. I had a little tiny ECG monitor, and I could monitor my dysrhythmias, and I could send them to a cardiologist who I knew, and I could speak to them remotely. And for me, that worked really well as a busy person. And I think there are some instances, if you're rural, if you're working, where for some elements of care, remote access is incredibly helpful. But there are some things you need to be present for, and that's recognised. HSIB have talked about this in a recent report. I have my own concerns about some of the statistics in that report around stillbirth, but let's not go into that. But I think that will get easier as technology improves. So we used not to be able to remotely monitor all sorts of things. We can now, your watch, I better not mention any particular make, but your watch can do an ECG for you. It can monitor your oxygen saturation. We can monitor blood pressure on phones now. So there will be much more we can do remotely. And that the oximetry for people with COVID has been incredibly important, and the rollout of that's been important. There are still challenges around that. And the safety netting that went with that, particularly around pregnancy, which we changed again recently in the light of feedback, to say there is a risk of what we call diagnostic overshadowing. So you believe your symptoms due to COVID, but of course during pregnancy they can be pregnancy related, and making sure people come forward when they're not feeling right, and the difficulties with the different ranges of physiology seen in pregnancy and so on. So there's an awful lot in there that we've already done around COVID specifically. As we learn this, we needed to have mechanisms. Part of the patient safety strategy was putting in place a structure around how we share all this information. So we have learning systems now that can share this information. There are the patient safety collaboratives, there are maternity networks, and so on. So there are a variety of ways in which this information is shared through networks. We now have 700 named patient safety specialists across our system who can also share this information, and we have a series of seminars already taking place for them. So I think the structure around safety that existed before has been boosted and enhanced in recent times, which helps us. I'll stop at that point, Mike, and let others come in.
Okay, no, thanks, Aidan. That's great. I think we may come on to the monitoring bit as well. I think, and particularly as it reflects globally in that, because WHO have just released some more information about what they think should be available on that. Susanna, impact in Singapore and a reflection on what have you done on the basis of changes in practice because of COVID rather than the state of play. So what actions have you put in place that you think that will be helpful to other countries?
Let's start with the patients first. I think the vibes I get is that the partners are not allowed to be in the delivery suite or to be with them or doing scanning. So what we did was we had an audit team who will go around and measure and make sure that in terms of safe distancing, even in the scanning rooms or even in where we eat, staff eat, for example, where patients are, we are still within that safe distancing kind of safety. So we are at the luxury whereby the partners are allowed in. And I think it makes a huge difference. I really feel for, I think as what TG brought up, the fact that when patients go into labor, they feel very isolated, when they have to manage their baby alone, for example. It actually helps a lot when the partner's around, even during delivery, the support, and even post-delivery, for example. So even for scanning, as long as within the room, it meets the safe distancing criteria, the husbands are allowed in as well. But I think what we've done as well in Singapore is that for patients who are coming into labour, they have to do the antigen rapid test. Husband and also wife, upon coming in, even if they're going straight to delivery suite, for example. And because the wives, when they go into labour, they take off their mask, and they sometimes, when they push, they breathe, the mask is off, and they're using Enternox, for example, they would need to do a PCR test thereafter. So the first screening is always with an ART. Any suspicious, they will repeat ART or add on a PCR thereafter. So at the first gate, it's anybody is positive, that's when they are not allowed in, and they will be referred to a tertiary centre, whereby they will be followed up further to make sure whether they're positive or negative. So I think the issue about having a partner in, it's also is of course very important as a work partner, as a support. Nevertheless, we do take into precautions. The other thing is about, in terms of the staff, for example, it was not very easy. I think Aidan brought up a very good point about, even staff vaccination, for example. We have to, at the current moment, with leadership, we have 97% of staff who are already vaccinated in KK Hospital. So it was not easy as well, but I think what we did different was the leadership make it very easy. We just walk in. We set up a vaccination center for staff and also for patients as well. They just walk in whenever they have a minute, and we have an area dedicated for them to be monitored as well. So in terms of vaccination, patients and also staff, again, initially was a challenge, but gradually we got a lot better. In terms of what we've done for staff, of course, fatigue, we cannot control when babies come out, and maternity is just going round over and over again. It's very hard to take dedicated leave as well, unless you take mandatory leave. Singapore is very small. The next minute your phone is ringing, even though you're on leave, for example, for some advice. So what normally we do is we encourage mandatory leave for staff. But we also, along the way, have got various committees, like mental wellness committee, to make sure that the staff are doing okay. It's all on the phone. All they have to do is just fill out a few questions at random, very, very easy questions. And there are set points whereby the moment there's a calculation and we recognize that they are at risk of perhaps breaking down, burnout, fatigue, it's automatic. They will be referred to. We have a dedicated carer service for individuals to present themselves to people who are neutral. It doesn't need to be their leadership, their reporting officers, and for them to voice out what their issues are. And these are individuals who are social workers who actually will listen in and give support and also opportunities for them to voice out and to see how they can help in one way or the other. I think the other thing also is the leadership, like for example, nursing or even doctors. We recognize that there's some who do not have their family with them while they're working in Singapore, for example. So they do have a buddy system. They have got a support group. They've got appreciation groups in the wards itself, just to make sure that they're well supported along the way. So it's not easy to reach that stage. Initially, there was a lot of hesitancy about being transparent, about opening up to say that you're missing your family, for example, even those who are in a leadership position. So I think moving to that culture, it's been 2 years already. We're getting there, we're getting better. There are a lot of support along the way, but it's just that we would want to see more of, I think it goes both ways, the juniors and also the leaders, to recognize the important, as what TG say, just be open, transparent, and just get to us whenever the staff has got issues or even the ground issues with patients as well. So I'll stop there and I'll chime in again in due course.
Okay, thank you, Susanna. I've just been chatting outside of the conversation just in parallel because I just wanted everybody to realise that we, as with many live conferences where these days we have very talented live illustrators, we also had that happening this morning, and we have a very talented live illustrator working in the background on her work. Sally is doing this work for us, So at some stage, when I have permission, I'll throw this up during our panel discussion so that you can see whether we can have it as it progresses or whether we have to wait till the end. And I'm just getting information about whether we can do that or not. So thank you very much, Susanna. Can I move to Mandy and Darren, if I may, just in terms of what your perspectives are of how the impact of COVID is having on services and outcomes in different parts of the world, through both your expert collecting information collecting system. So Mandy first, maybe from the from your perspective.
Yeah, no, thanks very much. Gosh, it's very interesting listening to everybody and their contributions. And from our perspective at the ICM, again, we've gathered information from the member associations, and the biggest thing that's come across is that we've not been considered, midwives, as I say, we have not been considered as essential frontline workers, and in some instances that meant that they weren't entitled to PPE, for example. So, you know, you really can't give safe care if the health professionals don't have the necessary equipment to ensure their own safety, and then in turn ensure the safety of the people that they're caring for. We also heard that, again, as has happened in many places, that midwives were redeployed to screening, COVID screening clinics, for example, or to provide care to patients who had severe disease. And of course that impacted on the shortage of midwives that exists anyway. And in turn, of course, that then led to an increase in unsafe and unsupervised birth, and it was really nice to hear people talking about respectful maternity care as well, because that's one of the ICM's sort of driving messages, is that care should be respectful. And of course, with units then being closed, so I'm sure Darren's got lots more examples than I have, but where units have been closed and rural facilities have been closed to try and centralise care more, particularly in rural and remote areas, families don't want to travel to areas where there's more risk. So what has happened is that they don't want to travel for care. The care isn't actually there. And the midwives that are there in the areas, in the rural areas, have got an increased workload. So that's another impact that we have seen. And of course, midwives don't just attend births, as we all know. They give antenatal care and postnatal care and a range of sexual reproductive health services. You know, the scope is quite varied from country to country. And look, they do all of this while ensuring that respectful care is delivered and by upholding women's rights. But it's been estimated that the deprioritisation of sexual and reproductive health services has led or will lead to 1.4 million unintended pregnancies. And this is just indicative of the way that when I came back earlier, when I first spoke about the human rights issues that's happening. And of course, as Jackie said when she first started speaking, that, you know, globally, that means there's 1.4 million unintended pregnancies. That means more burden on families as they lose mothers and babies as time goes on.
Thank you, Mandy. That's some amazing statistics there. Thank you very much for that. Sam, I don't know if it's possible to put up the live illustration, because I think it's going to be interesting to see how. I'm just viewing it on a separate screen I've got now, and it's interesting how without visual prompts, artists are obviously very good listeners in capturing everything that is being said here. So, Darren, could I ask you to really maybe sort of flavour Mandy's work, but also from the particular issue of the countries that you're looking at, what your views are? Thank you.
Yeah, thanks for that. And just to support some of what Mandy said, actually, I think this point about sexual reproductive health and rights is really important, and it's at the heart of an approach that we are taking to ending preventable deaths. There's a real global effort some countries to change the norms and standards, and they're pushing very hard in the UN system as part of a rollback on rights. And the UK is right at the forefront of resisting that, trying to maintain and even enhance the global positions, but it's very, very difficult. And our new strategy on ending preventable deaths will have right at the core of it work on human rights, gender and equalities. There's all sorts of issues I think Mandy was pointing to. And I should just say that we highly appreciate and respect the work that midwives are doing, and the partnership we have with ICM and others, particularly through the Partnership for Maternal, Newborn and Child Health, which I'm closely associated with. Your advocacy is fantastic, so thank you for all that you do. I mean, the truth is, it's going to take a while to know for sure what the impact of all this has been on services in the countries where we work, low and middle income countries. But we've got some insights. I mean, we know that more than a third of countries have reported disruptions to antenatal care and postnatal care, and that 25% of them have reported disruptions in facility-based births as well. And as you'd expect, it's not only access to care that's being impacted by the pandemic, but it's also the quality of care received. And there was a survey of healthcare providers for newborns recently, which demonstrated that 2/3 of health workers in 62 countries were saying that they did not allow mothers with suspected or confirmed COVID to have skin-to-skin contact with their small or sick newborns, and that's despite the fact that that's contrary to the WHO guidance. And we see the impact of these disruptions to access and lessening of the quality of care starting to come through in the data about health outcomes. So there was a study of 9 hospitals in Nepal recently where it came to light that stillbirths had increased from 14 to 21 per 1,000 births. I mean, a really staggering increase. And newborn mortality also increased from 13 to 40 per 1,000 live births during lockdown. So these are really shocking figures. So it's a very serious situation, actually. As I say, it'll take a while before we fully understand this. But it's shocking and it's serious. And in the global health policy space, much of the attention, I have to say, for understandable reasons, is focused on vaccinations and on future pandemic preparedness. So some of these issues are struggling to compete for global attention. And one of the ways we're approaching this is to say that we absolutely need to strengthen global preparedness against the next pandemics, and we need to get the systems in place to roll out vaccines. But we can do these things in a way that delivers win-wins, that gives us those strong systems that do deliver respectful maternity and other care, and which ultimately are going to be the front line against the next pandemic. That's where it will be detected. That's where treatment will need to take place. So we're looking for the opportunities, but it's quite tricky. Thanks.
Thank you, Darren. Thank you. We've got some live questions coming through, but I've also got a couple of questions I just want us to really reflect on the focus group a little bit before we go to the live questions. And I'm just thinking, TG, one of the elements that you mentioned was the issue of staff support, ensuring that you're visible, leaders are visible during this phase, and how do you protect? What actions do you think are important to protect about burnout and some of the mental health challenges? What's your reflection on that? Because this is a not just a local issue. This is a national and an international and global issue for us.
Thank you, Mike. So you're right. I think one of the biggest things about leading a team is leading from the front. And I must say that I look after not just women's and children's, but clinical support and everything. So I can't go to every place every time. But I was very fortunate that I had very good senior management and middle management people who also went daily to talk to the staff, attend ward rounds, speak to the staff, we did a lot of things which we didn't used to do before, and we think that some of it we can carry on in case it's another pandemic, or in fact during when we revert to normal. And these were things like every day one of my consultant colleagues would email everybody in the morning, if you're sick, let us know. This is what you should do for today, giving positive reinforcement to all staff by email. We had individual WhatsApp groups. We had one consultant looking after the junior doctors, just say, how are you guys today? Anybody need any help? Where are you short? And then of course we had the walk around and the walkabouts. And I thought that was very, very, very important, because of the fact that we don't want our staff to think they're alone in this. That's the worst thing possible. Now, what else did we do? So we recognized that a lot of psychological challenges to these are specialist midwives and doctors who don't look after critically ill patients all the time. Then suddenly you're facing with people who are critically ill. They were only sick if they couldn't get to ITU until they were really, really sick. So they had to care for these people they'd never been used to. I mean, some of my other wards obviously were converted from a pediatric intensive care unit to an adult intensive care unit. So can you imagine the change of the skill mix that our staff were faced with? And we were very afraid that they would go off the bend, so to speak. In the first instances, what we did is that we promoted a lot of well-being amongst our staff to speak out, to talk to us. At the end of each round, at the end of each day, we say, okay, the last 5 minutes, I want you all to look at each other and say, what went well today? Not what went badly, what went well today? How are my colleagues, how are my friends who are working with me today? And then you down tools and say, okay, and now I go back to my friends and not friends, but my family, and I look after them as well. So those are the things that we were doing. We were very fortunate also that I was very friendly with a really good group of bereavement counselors. And what they did, they extended a lot of help for our own staff from the psychological safety, coping with death in extremes, but also with things that happen during the day. And this psychological groups, we found that actually individual counseling wasn't as good as group counseling, and people were open and transparent into saying what happened, what could they have done better. Not so much as you naughty thing, but it's how we can support each other. Now, we were very fortunate that our trust looked after us very well. We had free parking, free food, free accommodation for people, like Suzanne was saying, from overseas and all that, who had no homes to go to. The hotels opened up during the first lockdown were particularly fantastic. There were hotels around our hospital units where they opened up the doors so our staff, for fear of going back and transmitting the virus back to their own family, stayed in the hospitals. We had free food, free car parking. So all these things were taken in place. And between the interval of the first and second wave, and second and third wave, we had what we call Staff Gratitude Week. Our trust gave free food, free singing, free dancing, or not dancing, but free music for staff to go to. And the CEO walked around, so everybody looked after each other. And I think that helped keep our staff with us and not leave for other places, but also addressing the fact that we really care for them. And we are very concerned and reach out to us if you have any mental challenges. So I think that was a good bit about COVID. Not much else was good, but I think this is what we felt were our positive steps we had for our staff.
Okay, thank you, TG. One last question from me, I think, and that's to really, I think it's a balance between Darren and Aidan, actually, or Jackie might have a view. I'm thinking more about the remote monitoring element, the ability to have resource available to support monitoring at home, particularly oximetry, blood pressure monitoring, where it's relevant to at-risk mothers, and also post-parturition at-risk babies as well. I'm just wondering, Is that something that's in the frame, is happening? Is that resource available, Aidan, for those who need it? And then Darren, do we have any views about how the UK is helping support remote monitoring overseas, possibly in the countries that you've talked about, where aid is a key issue for many countries? Aidan,
well, I'll start, Mike. I mean, there is some monitoring available. So we've been using pulse oximetry for some time. And I think there's a lot of detail that sits behind this. It's very easy, and we've seen this happen. People say, well, oximetry must be a good thing because we're seeing silent hypoxia. But there is this importance of the training and instruction and safety netting. And there's been some messages that have gone out there that have been quite worrying for people. So suggestion that pulse oximetry works differently in people with different coloured skin. And what we don't want is to put people off using these devices. Increasingly, people are using blood pressure monitoring remotely, but we've also, as you would imagine with the safety team, we're always looking for the balancing measures, and we've already seen people who've incorrectly measured their blood pressure, their treatment's been adjusted, and that's had an impact. So with all of these things, I mean, with pulse oximetry, it was sort of, there are 300,000 pulse oximeters, we'll put them out into the system. And I was really grateful. I mean, you know, in the height of this, I was able to pick up the phone to ARA, Lord Darcy, and say, please help us with this because we need to evaluate it as we go. We haven't got time to do the research into this, but we really need to understand who the groups are that will benefit most. And I think it's the same with any monitoring in pregnancy. There are groups who will benefit from this and there are groups who won't. And we just have to be cautious in doing this. And we could do this for CO2 monitoring, we could do it for all sorts of things, but it's really important when we use these devices to make sure they're used correctly and safely, because there are adverse effects of using this, and not everyone copes well with using them.
Great, thank you, Aidan, thank you. Darren, supporting low and middle income countries for resources in this field, and then we'll come on to the issue about maybe vaccination support as well. Thank you. It's come up in the live Q&A.
Yeah, thanks. So yes, I mean, our programming around the world had to pivot and start delivering in different ways, and remote monitoring was one of the things that we've been looking at and trying to adopt where possible. I mean, it's relatively limited. I think it's the truth in some of the resource constrained environments where we work. It's not always an option, but we have been using mobile phone technology, for example, where possible. On the well, and more sort of home base, you know, rather than bringing people together, we would go out and try and get the services delivered in a way that sort of reduced the crowding and gathering. On the vaccines, I mean, we're really worried about levels of vaccination in Africa, as you might expect, and the UK is getting behind the WHO process to produce guidance on global vaccination. We've been leading the G7 this year, of course, and we've got a commitment through the G7 to ensure 60% global vaccination next year. You know, it's not as fast as perhaps as many of us would like, but you know, it's something to work towards. We have committed to donate 100 million doses by the next G7 summit next June. We're on track to deliver 30 million of those by the end of this year, and we've contributed more than £500 million into COVAX, the global vaccination mechanism. But we all know that's been you know, faced some really significant challenges because of lack of supply. And now I think supply is coming through. I think the rates are picking up. We're expecting to see a big uptick over the last 3 months of this year, and it's desperately needed, of course. And now we need to help countries get their systems ready. So when those vaccines arrive, they are deployed, the people are willing to take them, and the systems are there to roll them out, and they don't go to waste, because that would be the worst sort of outcome. That would be tragic if these go to waste. So there's an awful lot of work going on that area, but yeah, I think we accept it's not where we ideally would want it to be at this stage. Thanks.
Thank you, Darren. And it's good to hear that this cross-governmental approach is working, particularly between health and support for our global communities around the world. We have a question here, unfortunately. Oh, thank you, David Grayson, for that question on vaccination in Africa. David's one of the leading lights in the Leading Health Systems Network, which is another Imperial learning network for safety from New Zealand. There's an anonymous question here, which looks to address, I think, poor culture, but also bullying. How do we ensure we are addressing the bullying and poor culture in maternity services that this particular correspondent feels has worsened during the pandemic? Mandy, what do you think about this? Is this an issue in the UK, or is this an issue globally about poor culture and bullying sometimes happening? I guess it's also a hierarchical question as well.
Yeah, that's a really interesting question. It's quite a challenging one for me because, as many of you will know, I've just transitioned to the International Confederation of Midwives from leading Each Baby Counts Learner Support, and prior to that working as head of quality and standards at the Royal College of Midwives. So I'm really aware of the situation in the UK, and Each Baby Counts Learner Support was desperately trying to address psychological safety. So we definitely know it. We definitely know it exists. We definitely know it's there, and we do hear reports. You know, in my last roles, definitely heard reports of that. But conversely, I think, speaking not from an ICM perspective, we were hearing also that there was more camaraderie and more support for each other when the pandemic first hit and things became really difficult. And that was sort of through the leads that we were working with through Each Baby Counts Learner Support. I think from the global perspective, you know, being relatively new to the organisation, I wouldn't have much that I can contribute to this from the ICM's perspective. But I do think it's something that needs to be addressed, and we absolutely know that people who are fearful, people who feel that they're being blamed, will not then escalate concerns, clinical concerns, as they arise if they're fearful. And of course, that just has an impact on unintended harm.
Okay, thank you. Thank you. Sorry, these questions are coming in thick and fast, so I'd like to just keep going on that. So Jackie, if I may, there's a question here, another anonymous one, and I think it says that you're actually replying to this post, but I just wonder whether you'd like to do that on the screen. So how do we address in real terms the racial disparity in childbirth? You mentioned it briefly, I think, as one of the ongoing challenges, and certainly Ara mentioned the outcomes element for that. Just wondering if yourself or TG would like to reflect on your own experiences across this part of London and maybe wider impacts in the UK.
Yes, thank you, Mike. I have typing furiously to try and respond to some of these questions. So absolutely, what I'd like to say is we published an equity strategy on the 6th of September, and that's a national framework, if you will, for supporting maternity providers. Number one, to ensure equity for those who use its services, but number two, to ensure equity of experiences of the staff who work in the NHS. So just recognising that if you don't, just going back to TG's very eloquent point, if you don't invest and value staff and respect staff, that will not translate to patients. So that is very clearly articulated in the equity strategy that was published on the 6th of September. And I think if services, we will support services through our local maternity systems to implement the equity strategy, but there is an onus of responsibility, I feel, that is placed on every single individual who is working within a maternity environment. Number one, to ensure that you provide equity to anybody that you meet, regardless of their colour of their skin or how they speak or their socio-economic status. And that plays to the Michael Marmot principle of proportionate universalism. We must apply healthcare, person care, any care, at pace and intensity, at scale, Michael Marmot says, at scale and intensity that is equal to the level of need. If we all did that and did it fairly and didn't judge by colour of skin, status, how one speaks, then I think we would be really on the road to ensuring equity. And just lastly, if I may say, pregnancy is 40 weeks of a woman's journey. If we're lucky, we might get 40 weeks. For most, we might get only 20 weeks. For some, we might get 10 weeks with them to impart health promotion, public health, that's empowerment and everything else to support them on their journey. So there is a wider societal challenge that we haven't got time to debate right now, but inequality, poverty, disparate health outcomes do not just exist in the maternity space.
Okay, thanks, Jackie. TG, your reflections. Thank you, Jackie.
I'm sorry, I missed the first part there. My reflections on what I'm really sorry about this, but my communication just got missed there.
On the racial disparity of outcomes.
Yeah, okay, so we've had lots of experience of it because we work in a very deprived area in northwest London. And sad to say, it is more common in our area here. What we've done is we have what we call case loading, where we got midwives that go out and identify these people who are challenged in all fields, not just the BAME, but also in other things, and like multiple pregnancies or medical disorders. And we go out to these people and give them personalized, as much as possible, one-to-one care, not just in the antenatal period, during delivery, but postnatally as well, because it's very important that we hand over these people who we have concerns about to the GPs and the nurse practitioners. I think it's very important. Like Jackie says, it is only a snapshot of a person's life, and it's important that we identify these risks. Then for instance, gestational diabetes is fantastic because we actually identify these risks early on, or hypertension or whatever. We then, in terms of transformative looking after these people, once we get hold of these people, we educate them, support them, and then we hand them over to the GPs. That's where we go. The whole life cycle of changes happens. So that's my reflection for this.
Okay, thank you, TG. So I'd like to come to a question that's been it's a challenging question, and it always comes from Jono. So Jono may be known to some, but certainly known to me and many of my colleagues over the years. So, and in various different guises, Jono appears. He's a great advocate and supporter of the Academic Health Science Network, and particularly in the Southwest. So his question, I will of course give my usual challenge. You have some brilliant speakers and panel members. Well done everybody on the panel. But when co-production is key to improvement, you don't have an identified patient voice with lived experience and maternity speaking from a patient perspective. Why is this? The reflection is that we've tried to do that. We've tried to do it with the focus groups, Jono, and we've obviously failed to you in that. We've tried to reflect, I think, what they believe was important in their experience, and we'll do better next time, and we'll challenge ourselves to do this. I think all the three, as you know, the patient safety translation research centres are all very committed to hearing the patient voice and actually walking in their shoes and actually ensuring that we do reflect that view. So I think we'll take away your challenge, and we will humbly try to do better. You also mentioned, and this is the question I want to ask the panel actually, you also mentioned about the fathers or partners voices. Can I just go back to the panel now then and ask the panel about what are we going to do in future then for partners' voices, fathers or partners' voices? Give as vaccination is improving in this country, but is stalling in many other countries. What are the views about how we engage more closely with a family rather than just the mother?
Can I maybe start with the
Jackie, thank you.
Perspective, Mike, just to say that a really good question, and it has been acknowledging the challenge that families have experienced during the pandemic when we've all been learning together about how we keep everybody safe who use our services. And so now we have produced guidance, which means that partners should be with women and birthing people throughout their pregnancy, birth and postnatal journey. We never stopped, and we never had guidance that said that women should not have partners with them during the birthing experience, but nonetheless, local pressures dictated actions that happened. But I can reliably say that now partners are actively encouraged to be with birthing people during pregnancy, birth and afterwards. So that's a huge start. There's a question in the chat about mental health, and absolutely that is a brilliant question. We have our perinatal mental health outreach services that are in early implementer stage at the moment. This is cited in the NHS long-term plan. This will mean that every woman and partner across England who has mild to moderate perinatal mental health concerns, who do not meet the threshold for IAP services or psychiatric services, they will have the benefit of timely access to these perinatal mental health outreach services. The question came because of the pandemic. I think the person that posed the question said many women are depressed and needing some kind of support. So that's just a direct response. It isn't the panacea of everything, but it is something that we are doing across England.
Great, thank you, Jackie. Thank you. Can I ask maybe each of you now just to think about what's your one message to close this session? If you had one message in one sentence, and hopefully a short sentence, please, about where you see yourselves, but where you see our action should be taking place to support our maternal and newborn health and safety. So if you could just think briefly, I'm just going to post now the illustration from Sally, and as many as you can see, artists are obviously great listeners. I'm married to one, so I should know that. But I think that here we have some great views here, and Sally has really captured, I think, many of the ideas that have come through. So lots to reflect on, and we'll make sure that this is available to all. While the others are thinking, we have recorded this, and this will be available for you in the very near future, as well as this vision for the future of safe care from Sally's perspective when she's finished. So if I may go first of all to Mandy. Mandy, what's your one takeaway message?
I should be very quick, but I think for the ICM, the takeaway message is that we continue with our advocacy work, and that involves the music to Jackie's ears. We're actually focusing a lot on continuity of midwifery care. So carrying on with the advocacy around the rights of midwives to work to their full scope, and also we are advocating for chief midwife in all our member states, which would enable really good leadership. So I think those are the two takeaways from us, that we'll continue with what we're doing and focus on the building of the relationship between the women through continuity, the leadership of the chief midwife, and our continuing work on respectful care.
Thank you very much. Susanna, Singapore, one of the leading quality systems across not just your part of the world, but the world. So what's your takeaway message for this particular theme of maternal and newborn safety? Sorry, Susanna, you're on mute. I'm sorry. You could unmute. Thank you. There we go. Try now. Susanna, you can speak. Can you speak, or have you frozen? Is it frozen?
Can you hear?
Yes, thank you.
Can you hear me?
Thank you.
Okay, right. Okay. I think there's something wrong with the connection anyways, but I get cut off on and off, but we'll be fine. I think what's important is having a visible leadership, as what TG says earlier on. It has to translate down to the ground, making it accessible as well, educating the maternity, the midwives, the support at all levels, allied health, every part of healthcare is very important. And I think the message to everybody is, with education, with support, we have to do it right from the very beginning. And from then on, we learn from mistakes. Things, we have to do away with this culture rather than that, right? So I just feel that I think this is a very good platform, and for us to be able to recognize, I mean, all of you have opened my eyes to a lot of things that you've done, a lot of good work. And I truly learned a lot from today's session. Thank you.
Thank you, Susanna, as we have from you. And you're very naughty because you threw in a lot of things in there, and you've taken some of the other people's ideas as well, I'm sure. Sorry. No, you're very welcome as a guest. You're very welcome. TG, over to yourself. What do you think? And then I'll come to Darren, just to give him a fair warning.
I think Susanna took the word from my mouth, but it is the constant communication and continuous support and education for our staff, because they are the most important thing, so that, as I say all the time, they can care for themselves and care for our patients. And I think we need just one last bit about vaccination. I think part of the reasons why vaccination was such a challenge, I mean, we have rates of 11% to 40% for maternity in Northwest London, which is appalling, is that I think when we're doing vaccines, people were a bit scared when it comes to research for vaccination to involve pregnant women from the very start. So we were at a disadvantage from kickoff when we're trying vaccinations studies, phase 1 trials and all that kind of stuff on non-pregnant women, and then it was hard to catch up with pregnant women. And that led to a lot of vaccination hesitancy, and I mean hesitancy more than anything else. I think if we were to do more trials next time, we need to involve pregnant women. It's going to be very hard because a lot of them don't want to do any harm to their baby. So that's one point there. Thank you,
TJ. That's your point. Thank you. Sorry to cut you off. Darren, over to yourself, and then we'll come to Jackie.
Yeah, thanks. I've taken enormous encouragement from today, so thank you for that. I think the takeaway for me is that we need to push ahead with our agenda on respectful maternity care and safety, and put that at the heart of the work we're doing on ending preventable deaths in a way that emphasises quality, but also there's really important equity points that we've been addressing, and build strong systems for all. And I'm encouraged by the fact we've got lots of co-travellers on that journey, and I'm looking forward to working with many of you on that. Thank you.
Great, thank you, Darren, and it's been a real pleasure to have you join us, and I'm looking forward to that journey over the next decade. Jackie, takeaway message from you.
Thank you. My takeaway message, I think, obviously I've only got one, and I would say that, the return on investment will be key if we listen, we understand, and we act. Without doing all three, we will be right back where we started from. Listen to women, people and their families, listen to staff who use our services, understand what they're saying, and then act. And the return on investment will be key.
Brilliant, brilliant. Thank you very much, Jackie. Thank you. Mr. Fowler, Professor Fowler.
Not yet, but I'm happy to take the offer. Last but not least, look, there's a lot going on in maternity. It's been a really encouraging discussion, and we've talked about staff and staff numbers, and they're absolutely key. And without wanting to take away from staff and their importance, I think there's a wasted resource here, which is the patient. The patient is most bought into all of this. And we are moving from delivering care to patients to delivering care with patients, but there's further to go on that journey, and we must do everything we can to empower them to support and navigate their own journey through this as safely as possible. And we must not waste that resource. And we have to find ways to do that better.
Great, thank you, Aidan. And we need to do that collectively and in Jono's words, co-productively, so that we become much greater than the sum of our parts. And for too many years, we've tended to work in isolated groups, and we no longer have the option to do that, either nationally or internationally. So thank you for that. I just wanted to close with the slide from Sally, if I may, Sam, and also to give you some apologies from the Minister who was due to be with us this morning, Minister Nadine Dorries, who, as many of you will know, has moved on to a new post this week, as the Prime Minister has shuffled his government. And so there's been a number of different changes that are taking place. So I'm afraid she's been unable to join us today, but I'm sure that once her replacement is settled, that person will be with us and leading and supporting Aidan and Jackie in their national endeavours, and many others in their international endeavours with great aplomb. We've talked for many years of this constant balance in safety, of transparency, of honesty, and of respect that is required, not just between clinicians, but between our patients and their families and ourselves as healthcare workers, no matter what our tribe is, nurse, pharmacist, doctor, manager. And more and more we understand now that relationship between those elements actually are key to building trust, and it's trust in our systems, both at a local level where we work together with our patients, that needs to be translated to a national level, so that whatever we do nationally really needs to make a difference to that conversation that takes place between our patients and their healthcare workers, nurse, doctor, pharmacist. It's of no importance, and midwife. It's of no importance which that is. So whatever we do nationally, we need to make it work locally. And I think that what we need to also think about now is how we see as a global sense, a global good of working collaboratively together. We've seen over the last 18 months the power that we can do that if we work consistently across the globe on one particular element, and now we need to do that on many different elements and work together in getting that place right. So I'd like to thank all of you for joining us today. There's been many from all over the place and many in collectives in different rooms, so thank you for that. I'd like to particularly thank our speakers and panelists for giving their time. Time is precious for everybody, and thank you very much for your time, and also thank you for listening. Thank you for the panel to listening to each other and respecting each other's voice, and also listening to those who ask questions. So thank you again for that. I'd also, and as everyone knows, a smoothly flowing swan has many legs underneath it. So I'd also like to thank all of those who've helped with the production of today's work, led by Anna, who's leading the Patient Safety Translational Research Centre, but supported by Alex, by Nikki, by Eleni, and by Jessica, and by Mabel, and others as well, but also in particular to Sam, who's led the production team for our work today, and also Sally for her endeavours to capture what you have said, what we have listened, and she has obviously listened well. So a great illustration, and one that we will use in the future and share with you. So thank you all very much for your time, for your listening, and I hope that we've helped you in your particular learning journey, and that we meet again very soon in person, because I'm missing everyone desperately. Thank you very much. Bye-bye.
Thank you.